In regards to this webinar specifically, I just wanted to highlight that this does not replace hands on training with the super users from your clinic. So, we're going to give a broad overview of the exam, lots of best practices, and a good foundation. But this does not take the place of any camera specific training that you'll receive if you are a new user at your organization. We also won't be addressing any billing questions today since those are specific to each organization. That will be one of the internal workflow questions that you can reach out to your manager or your supervisor to get some insight on. So this is a very broad overview. We've got a lot of different clients joining, providing this in a lot of different settings across many different organizations. We're just going to kind of give some broad overview of the exam to give you a really strong foundation and give you a chance to ask some questions of us. All right, so I'm going to go ahead. I want to real quick launch a poll. We just want to get an understanding of how many of you are new to performing the iris exam. So just two quick questions to get a handle on, if you've performed any exams in the past, and if so, how many? And then if you haven't performed exams, have you had a chance to practice at all with the device? So just take a few moments and answer those two questions really quick. Give us an understanding of where you're at in terms of your experience with the exam. Got a good mix coming in so far. About half of you, maybe a little less, haven't performed an exam. And then we've got some variety on how many exams those of you who have performed exams have done. Some people have practiced, some people have not. Really good mix. Okay. Few more moments for you to answer those questions, and then we will close the poll. All right, closing in 3, 2, 1. All right. So it looks like about 35% of those of you who have answered have never performed an iris exam. Of those of you who have performed exams, we've got kind of a mix of less than 5 exams and more than 10. And then a very few of you kind of in the middle there between 6 and 10. For practice, we've got about half of you who have not performed an exam have never practiced with the camera. I apologize, I read that wrong. About half of you have practiced, and then about 20% have not. Good little mix there in terms of, everybody's comfort level and skill gives us a really good understanding of where you're at. So thank you so much for taking the time to do that. Okay. So I'm going to turn it over to Corey, and he's going to talk about why this exam is so important.
Yeah, so diabetes is truly the leading cause of blindness that is preventable. It's literally preventable by just taking these photos of the eyes. This is a preventive measure whenever we do take these photos. And you can see there's roughly 40 million patients in the US that have diabetes and less than 50%. And I bet you if you think about it, if you were to say, if we referred out 100 patients to go get a diabetic eye exam, how many of those 100 are going to get it? I bet you most of you may have some that are in the 70s, but a lot of you are going to say like 3. So it is not like they're going to these referrals. So it's so important that you do this in-house because who sees all the diabetics? You all do. They all come to you because they have a provider. They have insurance and they or may not have insurance, but they still have a provider and they want to make sure they're healthy. And that's why this exam is so important. Now, again, if you referred out 50%, that still means that other 50 still needs this done, right? If they're being referred out, they have a retinal specialist, that is definitely not your target. Your target are the people who are not going. Could be due to the, hey, more that's, if they got referred out to a retinal specialist or something, that's more time out of their day. They have to schedule another appointment that's going to take time out of their day. If they're working, that's more time off. Now we're also talking about a specialist. So when they come to you, they may pay a copay, a normal copay, but if they go to a specialist, that copay is more expensive. So you literally not only going to save your patient time and money by becoming that one-stop shop, because there are so many diabetics out there that really need this, And as me, I'm a diabetic, and as I always tell, like if your patient literally could feel they have tingles in their feet, your provider is going to be doing foot exams every time they come in. They don't feel pain in their eyes, or it's really subtle, and they don't notice it until it's really late. And that's why this is so important and such a preventable way of capturing this early enough so it doesn't affect the patient. Because I ask everybody I train, you have five senses: sight, sound, taste, touch, hearing. I ask you which one's the most important one to you. It's going to be the most important one to your patients too. So you would much rather do this exam than ever. But again, so many diabetics out there, so many that are not doing this. And we really just, again, like it says, 3 million are about to go blind due to diabetes. Just by taking this photo, you have a way of, capturing this so we can get them the help they need before it gets so far along that it's impossible to recover from.
Absolutely. So, like Corey mentioned, diabetic retinopathy is the leading cause of blindness in the United States among working age adults. Blindness from diabetic retinopathy is preventable with early detection. And like Corey mentioned, many patients at early stage of retinopathy, they don't notice any changes to their vision. Early stage diabetic retinopathy frequently doesn't show any symptoms. So there are patients who have diabetic retinopathy who don't know it. And like Corey said, there's a lot of barriers to care, right? Transportation, specialty copays, and frankly, patient education. So we do often get asked when we're training, what does diabetic retinopathy look like? So we have an example here. The retina on the left, there's no pathology. The retina on the right has significant damage from diabetic retinopathy. So as that diabetic retinopathy progresses and damages the retina, it will, impact that patient's vision really significantly. And diabetic retinopathy, if left untreated, will cause complete and total blindness. So, as Corey mentioned, a very big quality of life change for those patients who experience it. Uh, well, the other thing we get asked is what does that look like from a patient perspective? So, how does it affect their vision? So, this is from the vision simulator that is on the IRIS website, retinalscreenings.com. If you use any of our patient education material, you'll see QR codes. Those QR codes do link to the vision simulator, and it allows patients to see or staff members to see what these conditions, what they look like from the perspective of the person living with that condition. So this is, normal vision without any diabetic retinopathy. And then this is an advanced stage of diabetic retinopathy. So pretty big change. As we mentioned, the changes are very subtle in the beginning. So obviously a person isn't going to go from this, kind of normal view to this overnight. But those changes are very, very subtle in the beginning. And so it can be really challenging. By the time a patient's notice changes in their vision, they're often at a later stage of diabetic retinopathy. And those treatments are very costly, and can be pretty invasive.
And one of the other things that's very hard because you have two eyes. They work in unison. They're constantly, adapting. If one eye is being blocked by something and your brain is still can see it, your say your right eye is being blocked, your left eye can see it. Your brain is telling you what you're seeing, right? It doesn't even affect. I worked with a patient one time who literally said, I found out I was going blind by laughing at my son, covering my right eye, and I couldn't see, uncovering it and covering it, and I could see. That is how she found out she was losing her eyesight due to diabetes, because your eyes work in unison. Again, like these dark spots ends up being, those are part of the bleeds, that diabetic retinopathy that are happening in the retina. And but if it's happening in the right eye and that same spot's not being blocked in the left eye, your left eye is going to compensate and adjust for those issues. So that's why it's so hard for them to realize it until it's extremely late.
Absolutely. So, this is one of the things Corey and I always start off with when we're doing a training. It is so important to remember why we're doing this exam. All of you are very busy in your day to day. You've got a lot going on, and so providing these exams at point of care, whether you're in a clinic or you're going into a patient home, we always think it's so helpful to connect to that why behind this specific exam, and how it improves patient care. And one of the other things we talk about is it doesn't have to take a long time, right? This exam can be done very quickly, especially the more comfortable you are. So this is a really quick way that you can, serve a lot of different purposes at once. You can close those gaps like Corey was talking about. You can provide better patient care. and you can help those patients and those eye care providers get an understanding, when a patient needs treatment, if they're not going to that eye care provider, hopefully once they discover something's going on with their eyes, they're more likely to take that referral so that they can get treatment and preserve their vision. So that is the why behind the exam. And again, this is so important to us. Our mission is to end preventable blindness, and so that correlates very strongly with you and your organization's, missions to provide better patient care and close those gaps. So let's talk a little bit about what we're doing during the exam. So, when we perform the exam, what is happening? We are taking photos of the back of the patient's eye. So, you're using a camera, a retinal camera, to take, a photo of the back of the patient's eye. So, we're viewing the patient's eye through their pupil. And so, this is one of the reasons that we like to have a darkened environment for the exam. And so, for those of you performing the exam in clinic, we recommend an exam room without windows. We recommend, having the patient come, sit down, turning off the overhead lights, and explaining the exam. And so that way, that allows their eyes to naturally dilate. For our operators who are going into patient homes, you've got a little bit less control over the darkness of that environment, but anything we can do to facilitate that. So you may have the patient close their eyes while you're about to perform the exam, or wear sunglasses. But that dilation is so important. We've got a visual representation here of why we care so much about dilation, and it's because the bigger the patient's pupil is, the more of the back of the eye we can see. And so it's really important for image quality that the patient's pupils are as big as possible. So a darkened environment really helps to facilitate that. The bigger the better, right? We want that pupil nice and big. Um, some of the organizations who are partnered with Iris will also use dilation drops when indicated. So if your organization allows that as an option, make sure you have a good understanding of what that protocol looks like at your organization. Of course, this will not be the majority of your patients. The majority of your patients are going to dilate pretty well in a darkened environment. But there are some organizations who choose to offer dilation drops as an option when those patients' pupils don't dilate well naturally. So if you have that tool in your tool belt, it's a very nice option to have because, again, the bigger the pupil, the easier it is to take photos, the more of the anatomy we can see, which is so important for image quality. Speaking of image quality, Corey, what should an image look like?
Okay, so this is an ideal image. We always want to kind of ask ourselves three main questions. Number one, whenever you take a photo, is the optic nerve in the correct side of the eye we're capturing? So the optic nerve should always be for the left eye, which is this image, should be at the 9 o'clock range, and for the right eye would be at the 3 o'clock range. So that's question one. So we always want to make sure our optic nerve is in the right spot because our other anatomy is connected to the optic nerve. If that's in the correct spot, our other anatomy is going to be there. Your second question, are all four parts present in this photo? So you're always counting to four. I want to make sure I see the optic nerve is one, superior arcade is two, macula is three, and the inferior arcade as four. So I'm always counting. And then my last question is it clear and in focus? That is my three questions after I capture an image that I always want to answer. Now, sometimes if you have like a handheld, we do have some flexibilities. You could take a second image of the missing parts. So what we always say for our handheld camera operators is whatever the eye has given you, if you're missing one, say if you've captured three out of the four parts, we need to capture the missing part to complete that anatomy. Desktops, you don't really have this flexibility, but handhelds you do. So we're always counting anatomy, and sometimes we can do that. That could take place in four different photos, potentially. But we have that flexibility with the handhelds. But desktops and handhelds, you're asking yourselves the same four questions. You want to make sure you want to make sure the optic nerve is in the correct spot. This image is over here on the right side. This is at 3 o'clock. And you can see both of these. We have both of them. But we want to make sure we are counting our anatomy. We have the four parts that are required for grading. And then is the image clear and in focus? Those are your three questions you want to ask yourself every time you take a photo.
So, assessing the quality of the image is a really, really vital part of the exam because this ensures the successful interpretation of the exam. So, the analogy Corey and I always like to use the comparison is, an EKG. A lot of you have performed EKGs or are performing EKGs, and you know that if one of the leads is not hooked up properly, you don't have an accurate reading. And so, it's really important that you understand what an accurate reading means for this exam. And so you should always be assessing the quality of your photos. There are a few cameras out there that offer some real time feedback on the image. And while that feedback is nice to have, one of the things that Corey and I always drive home when we're training on these devices is that you should be looking at your photos. You should be assessing their quality to make sure that these components are being met, that you can see all four parts of anatomy, that they're in the correct location, that they're clear and in focus. I cannot tell you how often Corey and I evaluate images that have issues in them, opportunities for improvement that could have been corrected during the exam. Things like a dirty lens, or the patient wasn't looking in the correct location. There are things we cannot control, like dilation. We talked about that. But there are things we absolutely can control, like a dirty lens. And so when you are getting your understanding of evaluating image quality, we provide examples in our videos and in the material that we provide to clinics as part of training. We give you examples of images that are not ideal so that you can have a good understanding what's happening in those images and how to troubleshoot them. So every time you take a photo, you should be looking at it to assess its quality so that you are increasing the likelihood that the interpreting provider can successfully interpret the image.
One thing I do want to add about the anatomy is we do need to see complete anatomy. I always say that the grader can't grade on what you kind of see. If you say one part of the anatomy, I kind of see it, just understand a grader can't kind of diagnose something. So you need to see complete ones. Like, for example, the number one is the optic nerve. It looks like a big sun or a tennis ball. If half of that is cut off, we're missing half the information. That is not a complete anatomy. That is a half anatomy. A grader cannot grade on halves. Same thing for the arcades. You can see the big thick one in number three where it's the big thick blood vessel at the top. Well, it's really, that's not where diabetic retinopathy normally shows up. It shows up in the tiniest little arcades falling all down. So if there's too much shadow cutting off that arcade, I don't have enough information, or the grader wouldn't have enough information to properly grade that. So we do need to make sure we see complete ones. That also goes for the macula. If I have a shadow too close to the macula, I'm going to say I can't see it because pathology a lot of times surrounds the macula. It's not always just in that little dot. Every macula is unique. We'll see dots, we'll see smudges, we'll see ones that blend in with the background, but I need to see that surrounding area, the brightness of this retina. I need to see that surrounding area, pretty much everything one, two, three, four. That's what I need to see. That is where I need to see. That's the clear, and you know, opportunistic, quality that I'm looking for of the image. I need to see all that information in that kind of sweet spot right there.
Absolutely. All right. So, again, if you are new to performing the exam, there are a lot of resources that we offer that cover this in a lot more detail, especially in terms of troubleshooting images that are not ideal on your specific devices. So, when you complete the onboarding with Iris University videos, there's a video on evaluating image quality. And again, there are leave behinds at all the clinics that show you examples of images that are not ideal so that you can troubleshoot those in real time. All right. So, when we are performing the exam, one of the key components is how we present it to the patient. It is extremely important that the patient understands why we're doing this and how important it is. So, one of the things that Corey and I always talk about is, your patients trust you, right? If you are presenting this exam as if it is something that is important for their care, they're going to take it seriously. If you present it like it's an option and it's not really that important and they may or may not do it, then they're not going to think it's important and they're going to be less inclined to do it. So, the comparison we like to use is it's like an A1C, right? Or a foot exam, right? You don't necessarily ask them if they want to have that done. You let them know that it's time for them to have that done because it's an important part of their health maintenance because they have diabetes. And just like we don't want them to lose a foot, we don't want them to go blind. And so, we just let them know, right? This is a medical exam. We're checking the health of their eyes. This is an evaluation of their eye health. This is not a vision exam. This isn't a vision test. This is a medical exam to evaluate the health of their eyes.
So don't call it an eye exam. It is not an eye exam because if everybody wearing glasses and contacts, if you say, "Hey, we want to do a eye exam on you," what's the first thing you're going to think about is getting a prescription. This is not what this is. You will get less, less pushback. It'll be easier for you. My saying is, "Hey, this is a diabetic health check. We're just checking the health of your eyes." You are talking about what is required here. Again, don't make this optional. This is a requirement. You want to make sure you guys are closing those care gaps. The provider is, understands their full body, how diabetes affecting the full body, rather than you just referring them out and hoping they get this done, which, as we saw, nationally, like 50% don't. So it is very important that we do this. Again, if you just kind of change your verbiage and make it present it as a requirement, not optional, you're going to be able to do this all the time for your patients. Because again, if you ask yourself, which is your most important sense, if you don't say sight, you're probably lying to yourself. It is sight, so, and it's the same thing for your patients. So help them help themselves is what I always like to say.
Absolutely. So, again, depending on the setting that you're performing the exam, your process for identifying your eligible patients may vary. If you're going in homes versus if you're performing this in primary care or in a clinical setting, the more that you can do to identify these patients ahead of time, especially if you are in a clinical setting, the better. The more that you can coordinate with the providers at your practice, if you're performing this in a clinical setting, the better, so that everyone has an understanding, right? When that patient presents at your clinic, that they're eligible for this exam, and we need to talk to them about it, right? And so it's really, really helpful to do, pre-planning, pre-charting if you can. Most of the practices that we see that are performing this in a primary care or a clinical setting are performing it during a regular visit, right? Diabetic follow up, or perhaps an annual wellness visit, capturing the patient when they're already there, instead of doing a secondary appointment. Although that is an option if your organization chooses to do that as well. So, this is one of those things, workflow is very customizable, which is a wonderful thing, right? You can find what works for you, right? When do we want to perform this exam? Do we want to do it at the beginning of the visit? Do we want to do it at the end of the visit? And that may vary, that may even vary day to day based on, how the day's going, whether someone's ahead or behind. And so one of my jokes when I'm talking to new clinics that are implementing this is, the good thing about the workflow is it's totally customizable. The challenging thing about the workflow is it's totally customizable because you may try a few things and see, oh, this works, oh, this doesn't. If your organization's been performing these exams for a while, and you're new, you are probably coming into a situation where they've identified what works, right? And so you just need to kind of find out what that is. What are your super users, your previously trained operators doing in terms of presenting the exam to the patient, identifying the patient, all of those things, because it is going to vary a little bit depending on the setting in which you're performing the exam. The other thing that's really helpful is to let the patient know what's going to happen during the exam. So we let them know that, we need to perform the exam. They've agreed. Now we're going to perform the exam. So we want to help the patient understand exactly what's going to happen. And your explanation doesn't have to be, very verbose. It doesn't have to be long winded. You don't have to explain to them what diabetic retinopathy is necessarily. Corey and I are a big fan of, simple language, but we do want to be, very explicit about what's going to happen during the exam. So when I'm talking to the patient, I let them know I'm going to take a few photos of your eyes today. We want to check the health of your eyes, make sure diabetes isn't causing any damage because that can lead to blindness. And we want to make sure that's not happening. When I take the photos, you're going to see a flash of light, just like from a regular camera. There is no pain or discomfort during this exam.
Or a puff
Uh,
of air.
or a puff of air. Yeah, that's such a common question we get. So, if you've ever had the exam where they puff air into your eyes, you know that's not comfortable. Your patients also know that's not comfortable. So, nobody likes that exam. So, it's very helpful to be, very, very explicit on the front end, right? This is not going to hurt you. This isn't going to be uncomfortable. There's no pain, no puff of air, just a flash of light from the camera, just like from a regular camera. You will also offer some additional instructions based on the device that you have. So, different camera types require different instructions. If you're using a tabletop camera, then you're going to be positioning the patient in that device. And so, you're going to need to know what adjustments to make. You're going to adjust the height of the table, you're going to adjust the settings on the camera to make sure the chin rest is appropriate. You're going to make sure that the patient is positioned properly. Those tabletop cameras, if your patient is not situated correctly in that device, it will not take good photos. So, one of the things we joke about, the hardest part of using a tabletop is making sure that patient's positioned properly. So, you're going to do that work initially, right, to make sure that they're positioned correctly so that when the device takes the photos, it can do that properly. If you're using a handheld device, it's going to be a bit more of a manual process. You're going to be approaching the patient, you're going to be touching them with your hands so that you can guide the camera. And so I incorporate that into my explanation. I let them know, that where I'm going to be placing my hands on their forehead, that they're going to feel my touch so I can steady the camera, and you want to make sure that the patient has that understanding, when we're using the handheld cameras. And then always, no matter what device you're using, your patient has a job, right? One of their primary jobs is to look in the correct location during the exam, whether that's an external fixation point on the outside of the camera or an internal fixation point, a blinking light inside the camera. Your patient needs to know where to look. We have to tell them where to look. Some devices require the patient to cover their other eye, some do not. So, these are all the specifics of your workflow that you're going to want to get a handle on when you start using the camera, when you're trained on using that device from the super users in your clinic. The more that the patient understands what's going to happen and how it's going to happen, the easier your exam will flow. So, I took a lot of time to say all of that. When you're talking to your patient, it's not going to take very much time, right? You're going to tell them what's going to happen, you're going to tell them what they need to do, and then you're going to take the photos. All right. Anything else you want to add?
No, just whenever you are discussing, she did mention, talking to the patient in a dark room. The reason we want to talk to the patient in a dark room is because number one, it's buying dilation time while we're in there, but we're also making that patient much more comfortable and confident. Dilation does not require 10 minutes. Honestly, most dilation for most patients, probably 80% of your patients, is literally within you turn up the light, they're going to dilate to the point where you could take this exam. So this exam can be done extremely fast. So don't think it takes a huge amount of time. Honestly, for a majority of these patients, it should be less than 5 minutes, total. That's from you sitting them down, turning out the lights, explaining what you're doing, why you're doing it, how, and getting going and taking the photos. Honestly, for a majority of the time, it should be less than 5 minutes. Anything over that, you're wasting your time and the patient's. But there are some times where patients may need some additional natural dilation, or you may determine that they need to be, if you do dilation drops, you may need to administer those because dilation drops do take time. If you're trying to let them dilate just a little bit longer, then we want to do that up to a max of 10 total minutes for natural dilation. Drops require basically 10 minutes to come into effect, but you could also try it earlier because those drops are taking effect. And because the drops are basically mitigating and opening up those pupils, even if you flash their eyes, it's not going to affect the pupil. It's still going to continue to grow because the medication is taking place. So, just a little bit, we do have another webinar on dilation itself. So, please refer back to our YouTube page to check those out because there's lots of great information on there as well.
Absolutely. But Corey, you brought up a great point. You do not have to throw a patient in a dark room for 10 minutes. That is never going to be our recommendation because it's just not very effective. Most of your patients don't need that much time. So, this really is a place where you can save a lot of time in your workflow. If you're in a clinical setting, the sooner you get that overhead light turned off, the better. I turn that light off before I explain anything, before I clean anything, before I do anything else. I will leave the door open a little bit, or I'll leave a computer monitor turned on so that I can clean the equipment, explain the exam. You don't want to go into a completely dark room, but the sooner you get those overhead lights turned off, the better.
Absolutely.
All right, so we have identified the patient, we have performed the exam. Now, what happens? At some point, you are going to perform the exam and then you are going to upload the images. And again, the way that you do that is going to depend on the device that you have. So, some of the devices you will upload the images straight from the device. Some of the devices you will dock the camera and you will upload them after the exam. But whatever that workflow looks like for you, you got to send those images, right, to Iris. And those images will be interpreted, right, by a licensed eye care provider. That eye care provider is going to identify whether pathology is present. They're going to be evaluating that image based on, they're looking for diabetic retinopathy and macular edema. They will also indicate if they see evidence of other types of eye conditions. And so every organization that we partner with signs off on a care plan of their choosing, so that they dictate what that patient should do based on the findings. So you'll upload those images to Iris, they will be interpreted, and then those results will be returned back to you. Again, the method of return and retrieval is going to be different depending on your organization. So those might come back to your EMR, or you might go to the Iris portal to retrieve them, or there may be another method by which those results are returned. That'll be specific to your organization. We customize that based on the organization's needs. So these are some of the questions you're going to want to get answered if you're a new operator. The people that are training you in your clinic, right? How do we get results? What does that look like? So that you can have an understanding on closing that loop, right? So that that gap gets closed in your system. There's going to be an ordering process in your system. There's going to be a billing process. All of those things, again, are going to be specific to your organization. So, when you're talking to the patient, and I'll typically keep it a little bit, general. I'll let them know, we're sending these up to an eye care provider so that they can evaluate them. And then they'll send those results back to us and we'll deliver those results to you when we have them. It's usually a pretty quick turnaround. But you do want to give yourself or your providers a chance to evaluate those results, so that you can deliver them to the patient. So, kind of helps to give a little bit of a buffer there as well. Again, if there is pathology identified, there's going to be instructions based on that pathology. Usually, it's going to be some kind of a referral to an eye care provider, so that that patient can be evaluated and treated. And so, if there's no pathology, then that gap is closed and that patient can return back to you the next calendar year for an exam. So each time you're performing the exam, you will get those results to let you know what the findings were, if there were findings. And so this is really helpful because again, it closes that gap for you right there at the point of care. All right. The last thing we want to talk about is what you need to do in order to be ready to perform exams yourself. And just a reminder, I haven't seen any additional questions come through, but if you do have any questions you'd like us to answer before we conclude the webinar, feel free to put those in the Q&A box at the bottom of the Zoom meeting. All right. So, what do you need to start doing exams? There's a few things that will get you set up. The first thing is that you need to be added to the Iris portal. This will give you access to the training modules that I referenced earlier. So, Iris University, as you can see on the PowerPoint, we have video modules that are specific to the camera type that you have. So, there's going to be a video on how to take images with the device that your organization has. There's going to be a video on talking to the patient about the exam, one on evaluating image quality, one on dilation. So, kind of an introductory video for each of the topics that Corey and I have kind of, discussed today. It's going to be a little bit more detailed than we have been able to be, and it will be specific to your organization's workflow. So, that's the first step, right? You want to get added to the Iris portal. Your manager or administrator should be able to complete that task for you. If they're not sure how to do that, or if they need help, they can always reach out to Iris. We're happy to facilitate that for you. The next step is for you to get hands on training, right? So, as we mentioned at the beginning, this webinar is meant to give you a foundation, but you've got to learn how to use your specific device. You've got to learn what your workflow is based on your organization. So, you're going to get with the super user at your clinic, a previously trained operator, so that they can help you understand what you're doing at your specific location. It's very, very helpful for you to have your images captured. So, whatever camera you're using, have someone who's trained already take your photos. This is so important because it allows you to see the patient's perspective. You can see that the exam doesn't hurt. You can see what it looks like so that you can better explain it to the patient. So, I see a lot of times I come back to do training and there's people who are performing exams. Maybe they're a little reluctant or they think, it might hurt. And I realize, oh, they've never had their images taken. So that's a really helpful part of training. It's also helpful for you to observe a few exams being performed if possible. So, kind of the see one, do one, teach one approach, right? So, you receive that hands on training and then you watch an exam being performed, or maybe two. And then maybe someone watches you, right? A trained operator comes in the room with you and you kind of have a buddy system in the beginning so that you can get a better handle on that process. And then, Corey, I know you and I talk about this all the time. What's the most important thing that an operator can do?
What I
I
talk,
put you on the
yeah, put
spot.
me on the spot.
It's practice.
Yeah, practice, practice, practice. Can't stress that enough. It is the most important thing. I always compare, like, especially handhelds. This is like riding a bike. You didn't learn how to ride a bike in a day. You had training wheels, you had some things that helped you how to figure out that balance, pedaling and steering. But you had to practice to get good. After a while, the training wheels went off. After a while, you got so comfortable you ride without handlebars. Then you could put that bike down for like 2 years and jump back on and just take off because you build all that muscle memory. But especially, I can't stress this enough, handhelds, you need to practice as often as possible. Desktops, you have a little bit more leeway because pretty much the camera does a majority of the work besides you getting the patient set up and stuff like that. But you practice a few times, you're good. But handhelds, you need to practice at a minimum once a day for 2 weeks. If you do that, spend 2 to 3 minutes. Just spend 3 minutes a day for 2 weeks. Every day you work, I'm picking up the camera. If you have patients in between, those are bonuses and you are working on them. But if you do that, that's 30 total minutes. That is not a long time, but every day you pick up the camera, something else is going to click and it gets easier. It will get easier every time because there's a bunch of little things that all lead to the ultimate goal. And those little nuances are what really strengthens and makes you a stronger camera operator for the handhelds is by practicing getting comfortable with your device, getting very, very comfortable.
Yes. And one of the things I like to talk about, a lot of times we're working with people who have been in, their organization for a while or their job for a while. They know the processes they're doing day to day. They can do them in their sleep. And then they start to learn something new and it's a little intimidating. It's hard to learn something new. It can be challenging, especially if you're not perfect at it right away, which you probably won't be. I mean, that's the whole reason Corey and I have positions as educators, right? We have to help educate because it's challenging to learn something new. And so, one of the things I always tell, operators is you just have to kind of embrace that it's going to be hard at first. You have to understand that there's kind of a hill that you're trying to get over, right? There's a learning curve. And like Corey said, getting over that learning curve doesn't have to take a long time. Grab a buddy, take a few pictures of them each day, grab different buddies, right? The more different eyes that you can take photos of, the more circumstances that you're going to see in terms of pupil size and in terms of difficulty with image capture. Your patients are going to be great practice, right? There's going to come a time where maybe you're not very comfortable still, but you need to perform exams, and that's okay. It's just like any other process you've ever learned. You're never going to be 100% comfortable right off the bat. You're going to have to put in a little bit of time and effort to get comfortable. The more comfortable you are, the easier and quicker this exam is going to be to perform. And Corey and I learned this camera, all of these
Oh, yeah.
devices, the exact same way that we show people, right? When we came to the company, when we started working at Iris, someone showed us how to use the camera, and then we had to practice. We had to get comfortable, right? And that's taken a lot of time, and there's things that we can do today that we couldn't do a few years ago. And that's because we've had time with the camera, we've had time with the device. So it's kind of a fake until you make it, which is okay. That's, what all of us do.
We get manufacturers will send cameras to us, and we have to figure out how to use them. Because every camera manufacturer is kind of different. Me and Lauren have to know 20 plus different cameras. Your goal is only one. So if you can know, if we can know 20, you guys can learn one very easily. One thing I do want to, this is going to cover for everybody, but one thing I do want y'all to do is go to our web portal. If you have access to Order Manager, I would love for you to work with your teammates and review what images are not gradable. Like every 30 days, have a one day where we're reviewing our images and make sure you guys go to Order Manager. You can pull up every non-gradable that the whole team may have captured, right? And then you guys can discuss why it's non-gradable and learn from that. Learn from your mistakes will get you better to a better spot, because everybody, me and Lauren, are not perfect with all these cameras. We make mistakes too. That doesn't mean you guys are going to be perfect either. So, because we're not, but it's just by learning from your mistakes. We learn from every mistake we've ever taken. We learn from the images you have taken and understand why, because we can literally tell you from what camera manufacturer your camera took and literally what happened for a large majority of the photos you take. But just want to end off with that one. But sorry.
Yeah, absolutely. And we talked about that in the most recent newsletter, where this is Corey's suggestion of reviewing images that were not gradable so that you can get an understanding of why. And different people are going to have different strengths in the clinic, right? One person may have a better understanding of using the device, but may not be as comfortable explaining the exam to the patient, or vice versa. So by leaning on each other and by using each other, like Corey said, as, sounding boards, you can learn from those mistakes as a group. And again, it doesn't have to take a long time.
Mm.
5 minutes in a huddle that you have once a week, talk about the opportunities, talk about the challenges, have discussions with each other about what you're struggling with or what you're doing well, so that you can lean on each other and as a whole have a better understanding of, the exam. So we've got a question on what you do to see ungradable images. So that's going to depend on your clinic. If you have there's an application in our portal called Order Manager that you can view images in. And so some of the users at your clinic may have access to that. Your manager may have access to that. So that's one place you can view them, is in our portal. If we're integrated with your EMR, you can also view them there at the, in the patient's chart. When you get that result returned, you can see, the images that were uploaded. So if you have questions about that or you need assistance with accessing that, you can reach out to us. We're happy to help
Yeah,
you.
it's in the same portal as IrisU. You might have camera operator, and you may not just have the credentials to see Order Manager, but most likely your manager would, or one of the admins can give you access to that, so you guys can review those non-gradable images.
Absolutely. So access is just, based on the user, and that can always be, added or changed, as needed. We also had someone ask about finding the results of the exam in Epic. So it sounds like we may be integrated with this particular clinic. Where you see those results in your EMR is going to vary. So you're going to need to get with a trained operator at your clinic to understand what tab those results are under, where they come back. Because all of our clients use different EMRs, and even clients who are using the same EMR, those results might return differently. So that's going to be specific to your organization. So get with a trained operator, find out where those results are coming back to and how you can access them. If you're integrated, what does that look like in your EMR? If you're not integrated, how you can log into the portal and access those results from Iris. We also have instruction guides on all of our applications. So if you run into issues or challenges with any of the apps and you need help, you can call our help desk, or, we can send you the instruction guide. A lot of it's very intuitive. So it just kind of, once you get a handle on where you're going and what you're doing, it's pretty easy. But sometimes, it's helpful to have that boost initially. Great questions. All right. So, one of the last things I like to talk about, kind of coming back to one of the things Corey and I were saying about practice, perfection is not the goal. right? You're never going to have perfect gradability. Even if you use dilation drops, there's going to be times you just can't get a good image, and that's okay. Our job is to take the best photos we can with the tools that we have. And so there's a clinical impact, right? Every time I upload an image with the most anatomy that I can show the interpreting provider, I'm giving that interpreting provider the chance to see pathology. And so any patient in your chair is a win. It's okay if you don't get perfect exams all the time. Corey and I don't even get perfect exams all the time, like he said earlier. So the importance is that you are making an effort, right, to be better, to learn, to improve. The worst thing that you can do, right, is put that camera down and not try to do exams, because then you're never going to improve that way. You're never going to get better. So just understand it is going to be a little more challenging in the beginning. It might take you a little longer in the beginning. Be gentle with yourself.
So
Give yourself the chance to learn. Give yourself the chance to be better. Because I promise you, Corey and I, we are not special, right? We just have practice. And so if you have practice, you will get better.
yeah. Just like riding a bike, you fell down a few times, skinned a knee, but you got right back up on the bike and took off. Same thing. Non-gradables are to be expected, but just don't let them discourage you. Keep trying. You will only improve with every exam you do. Remember, again, we're looking for 4 parts of anatomy per eye. If you're missing one, the grader can say it's not gradable, but there are times where you might only have one part of one eye, but if they see pathology, the whole exam becomes gradable. You literally just save that patient's eyesight, because we know diabetics are not doing this every couple months. We're lucky if they do this once a year, and that's why it's so important to require them to do this rather than ask them.
All right. We've got a question regarding dilation practices if the organization is using dilation drops. So, that question is also going to be specific to your organization. So, whether the patient signs a form or answers questions for dilation drops is going to be dependent on your organization. Whether they need a driver is going to be dependent on your organization. So, it's really important that you get an understanding if dilation drops are an option within your organization. You need to know what that protocol looks like, what the order is, and what the steps are to use drops when indicated. Again, that will not be for the majority of your patients, that will be a small percentage. But every organization that uses drops, they create their own protocol around what that looks like. So you're going to want to get with a trained user to let you know what that looks like when you are using dilation drops when it's indicated. Good question. I apologize. I know some of this stuff is a little challenging because we are partnered with so many organizations that handle these things in so many different ways. But again, there is someone at your clinic who knows what that process is. You just got to find them and get a handle on what that looks like for you. Great questions. All right, we are nearing the top of the hour. So if you have any additional questions, please feel free to put them in the Q&A box now. And as I always like to remind everyone during our webinars, this is not the only chance that you have to reach out to Iris. We perform webinars ongoing, and we also have our help desk, right? So you have the option of reaching out to us via call or by email. Our help desk is always available. They are extremely responsive. So if you think of a question, maybe you log off and then you realize you wanted to ask something and you forgot, or maybe you were a little shy to ask it on the webinar, please reach out to us. Iris really does care about you feeling supported and you having what you need. All right, we got another question. So, Corey, do patients have to remove contact lenses before you perform the exam?
They do not, with one exception. That is, if you administer dilation drops, contacts do have to be removed because we need that medication to coat the eye so that the pupil will open up. But for everybody else who are not administering dilation drops, or you don't have to administer dilation drops for that patient, contacts do not need to be removed. Of course, glasses do, but contacts do not. So it's not going to affect anything of your photo with the contacts they do have in.
Absolutely. All right, we've got another question. Can we get images of an eye with no vision? So I'm guessing they're talking about a patient who maybe is already experiencing some level of vision loss. Can we still get their images? And the short answer is maybe. Probably. So, patients who have already experienced vision loss, it is still helpful to perform this exam, right? So that we can get an understanding of what's going on with their eye health. While you may not necessarily be able to prevent them from that vision loss, especially if they've already experienced some vision loss, there are conditions that are indicators of other health issues that that patient's having related to their overall body health. So, saving their vision isn't necessarily always the primary goal. Additionally, if they have retinopathy and they're not being treated for it, that condition can become very painful as it advances. So, Corey and I always recommend try to take photos. If you have a patient that's already experiencing vision loss, it may be challenging to get good photos, but there's still, again, a clinical impact to trying to perform that exam to get an understanding of their overall health as it relates to the eye, because you can see a lot from the retinal photos, right?
I always say it's not. They always say the eyes are the window to the soul. It's actually the window to your health. There is so much just that anatomy in the back that can such a story that it can tell about the patient's health just by taking photos. I mean, not only can our target is kind of diabetic retinopathy and macular edema, and that's due to insurance companies and all that. But whenever you take these photos, there's going to be a whole host of other suspected pathologies that we can find. There's even ones that say are emergent, like an emergency finding that this patient needs to go to the emergency room. So you potentially, as this sounds, I mean, we're trying to literally save someone's eyesight, but you have the potential by taking this photo to literally save someone's life potentially as well. We normally get about, on average, about 1 to 2 a month of an emergent finding. We're at a clinic just last week, and Lauren, we had five. She had 5 patients, and one of them had an emergent finding. So by there, we literally just save that patient's eyesight and life basically by capturing this image.
Absolutely. Yeah. So the patient had a condition called papilledema. It's a swelling of the optic disc in both eyes, which is an indication of intracranial pressure. So, like Corey said, that's not just a vision save, that's a life save. That patient needs emergency care. And while those are rare, those are findings that are happening in iris exams. We did a great webinar with Dr. Gross, our CMO, last year. He is a glaucoma specialist, and he went through a lot of the different pathologies that are commonly found in iris exams. He talked a lot about diabetic retinopathy and macular edema. We also talked about glaucoma and macular degeneration. And at the end of the webinar, we discussed that type of emergency finding, the swelling in the optic disc. When it's in one eye, it's urgent. When it's in both eyes, it's emergent. So there are a lot of things that can be detected from these retinal photos. So, it seems kind of strange. We talk a lot about, ending preventable blindness and preserving a patient's vision, but there are other factors at play when we're taking these photos. Great question.
Absolutely.
You all have asked a lot of good stuff today. It's always nice when we can address these things in real time, so that we can, make sure that we're targeting things that you're wondering about. All right. We are getting close to the end of the meeting. So, again, I just want to thank you all for joining us today. We did record the session. We will provide it in the upcoming September newsletter. As we mentioned at the top of the hour, we have recorded all of our webinars. They are available on our YouTube channel. We also link to that in our newsletter. So, lots of resources available to you. We are here to help. If you need anything at any time, don't hesitate to reach out to us. We are happy to assist you. And again, we really thank you for all the efforts that you're making in helping to close these gaps and end preventable blindness for your patients. So, thank you for joining us, and I hope you all have a wonderful day.
Thanks, everyone.
Bye bye.